what I would like to do tonight is kind of give you an overview of what we're doing. So it's impossible to go in details on all the project, but I wanted to give you a flavor of the research we're doing now and where I think we're going to be in 5 and 10 years from now. So again, I'm going to be talking about regenerative medicine in orthopedic surgery. And as you know, I moved here on May 1st, 2015. And prior to coming here, I was at the University of Pittsburgh for 20 years. Why I'm showing this slide here is because a lot of the research I'm going to share with you tonight was done at the University of Pittsburgh, and now we're following up on the project that we're doing. So first, I just wanted to tell you, what we have set up, over the last year. We have established a Regenerative and Translational Medicine Institute where I wanted to have a side that's going to be basic science and a side that will be clinical translation. So this is why, I think, with the way we set this up, so we're doing basic science in orthopedic surgery at the University of Texas in Houston, and we're doing the clinical translation in regenerative medicine right here. Why we wanted to do this? Because we have probably one of the best surgeons in sports medicine right here in this place. So we thought that would be an easy clinical translation. But what happened now is we're doing a lot of basic science here too. So the bottom line is we're doing basic science in both sides and clinical translation, in both sides as well. So you may ask, which area of research you're doing. So we're doing a lot of things in orthopedics and sports medicine, but I'm going to be talking tonight about aging. I'm not going to be talking about cancer, but we have also a project on cardiovascular neurodegeneration that I'm not going to be talking about tonight, but the same tool that we're going to be using in orthopedic surgery will be used for those different applications. So when I came up with this idea to build an institute, so I had to convince two persons to be behind this. And the first one was Walter Lowe. I have to say that Walter wanted to recruit me in 2013 in Houston, and I always find a good reason to say no, to not going there. I said, well, I'm a Canadian, it's too warm out there, and so forth. But the bottom line is, in 2014, I told him, I said, okay, I'm decided I'm going to move in Houston. This is when Mark Philippon called me up in middle of July, and he said, Johnny, we're looking for a stem cell researcher, tissue engineering. Do you know anybody? So I said, please don't ask me because I just gave my verbal commitment to Walter Lowe to move in Houston. He said, don't sign anything. Come here. And so I came here and I saw the place, and and I really fall in love with Vail, to tell you the truth. And after this, I said, came back to Walter, and I said, I have a bad news. He said, what again? I said, well, I want to come here, but I went in Vail, and I fall in love with Vail, and I think it will be a great place. And so this is when Walter said, well, you don't have to come in Houston or decide between Houston and Vail. Maybe we can do the two together. Maybe we can do an institute that's going to be between together. And this is what we decided to do. So here, I don't know if you can see this from behind all the way in the room here, but the bottom line is, again, we have an institute where we have a site in Houston where we have 6 labs, as you can see here. And we have also the site here in Vail where we have 5 different groups, as you can see here. And one big advantage to be here to do orthopedic surgery, certainly the large animal model in Fort Collins at CSU, because a lot of thing we want to do to try to improve cartilage repair, bone repair, you want to go in large animal model. And this is, what's very appealing to me. But also, again, one thing that I want to say is even if the basic science is being done here, then that's coming on this side as well. And we have this seamless, bench-side to bedside, type of, application here. So again, when you decide to do something like this, then you have to convince people to work with you. So the first thing is the group that I brought, at Houston are many people that was working with me in Pittsburgh for the last 20 years. And that's one of the main reasons, I wanted to move is they were under me for so long that they wanted to be promoted and they were incapable to. So by moving in Houston, so all of them become assistant professor pretty much. So this is the team that we have in Houston, and this is the team that we have in Vail. And again, the group here is growing because we're missing some people. And at the end, I'm going to acknowledge the people that have joined the team. But here as well, we have probably 5 or 6 more people. But those two teams, are great. But I really believe that the combination of both is really what makes it so great. Because I think, this is a picture that we did at the Vail Scientific Summit last summer. And that was the team that we put together. And again, we're going to have the second here, we're going to have the second version of this Vail Scientific Summit later on, this year. And I'm very happy by putting this group together. So another thing that I want to share is science is like I'm telling you, let's build a football team to win the Super Bowl. Then you're going to say, well, if I tell you can pick up any player you want, then you can say, okay, I'm going to pick up this quarterback, I'm going to get this, running back and everything. So this is what we did in science, basically. So we decided to collaborate with a lot of people. And again, here this is just, we have more people being involved, but the Rice, Baylor, MD Anderson is great in Houston. It's very rich environment to do science. Texas Heart, we have a grant with the Texas Heart. Mayo Clinic, the Scripps, Northwestern University, Fort Collins, A&M College Station, UPIT, UPMC, CMU, Vail Valley Medical Center, also HSS, because we have a collaboration now with the Hospital for Special Surgery. And you can do a lot of this, but the funding is very important, because if you don't have any funding, then it's very difficult to do science. So I think the funding, as you can see, we have funding from many different agencies, which is very important. Okay, so now I'm just going to try to tell you a little bit what we do. So I think orthopedic surgery has been, for a long time being biomechanics. That was the only thing we were doing in orthopedics for a long time. But and I remember, when I went to my first orthopedic surgery ORS meeting in 1996, and I will tell you that they had only probably 3 or 4 sessions in biology, and the rest was all biomechanics. So this is when I told the guy that recruited me, I said, probably I joined the wrong department because I don't do biomechanics. But over the last 20 years, biological solution has become, really important for orthopedic surgery. And again, if you want to develop something to improve tissue repair, then the biomechanical factors are key. Again, if you want to repair the knee, if you want to repair cartilage, then you have to understand that this is under constant load. And if you try to repair that tissue, then you have to keep this in mind, that biomechanical factors are very important. Gene therapy, now we can turn on genes, we can turn off genes, we can activate genes. We can do a lot of things now with gene therapy. Cell therapy, well, I'm going to talk to you tonight about stem cells. This is part of the stem cell therapy now, and those stem cells can be used for a variety of tissues now. And tissue engineering, because if you want to repair cartilage and you want to put the cells into the osteochondral defect, then you may want to use a scaffold to keep the cells there, a plug somehow. So tissue engineering, you have a lot of people that develop those scaffolds that's going to be able to be used, for orthopedic surgery. And all of that combined, this is what I call regenerative medicine. Regenerative medicine is not only one technique, as you can use cell therapy, gene therapy, and tissue engineering. You combine the two together, and this is what we do. So here is really, we were on a cover of Journal of Orthopaedic Research, a few years ago. Well, almost 7 years ago now, 8 years. But the bottom line here, we're trying to tell people, what do we think, regenerative medicine entails for orthopedic surgery. So you have to have cells, you have to have scaffold, but you have also to have factor like BMP or, a VEGF to push those cells to a certain tissues. And this is what we have been doing for the last, almost, 20 years in our group. So here is just a sampling of, 4 or 5 projects. So you can see we have 5 NIH grants currently funded in the lab, but I just wanted to show you that we have grant on muscular dystrophy, we have grant on aging, we have, also grant on, cardiac repair, we have grant on nerve repair, and of course, the last one here is on bone and cartilage. And this is the grant that are funded currently. And we have also grant now, that we're trying to, here is a drug that we're using, to block fibrosis, because we found a drug that can block TGF-beta1, and TGF-beta1 is really the cytokine that will promote fibrosis, and now losartan is being used, and this is funded by the Department of Defense. The Department of Defense, came to us and they gave us a grant to try to treat those soldiers, with the drug, that was already approved. By the way, losartan is being used every day for cardiothoracic surgery to prevent scar in your heart. So we're using the same drug now to prevent scar tissues in your muscle. But we have also a lot of things that we're doing here: exercise, neuromuscular electrical stimulation, massage, which is very important for tissue repair, regenerative medicine of ACL, and finally, we're doing a lot of things also for the microfractures. I don't know what happened there, but this is a project that we're doing with Fort Collins. So one question that you may have is, okay, where are you with this technology? So here is a pipeline of regenerative medicine from our group that we developed. So we're using those cells to repair the sphincter, the bladder sphincters, in patients that suffer from stress urinary incontinence. Those patients leak urine when they cough and sneeze, and we take stem cells and inject into the bladder sphincters. As you can see here, we get in clinical trials in 2006. Now we have over 500 patients that has been injected. We're in phase 3 clinical trials. Cardiac repair, we started this in 2010, 2009, 2010. Here we have less patients being injected, but we're already in clinical trials. Compartment syndrome, I told you losartan trials, that started in 2012. But you can see a lot of projects here, PRP stem cells in orthopedics, and skeletal muscle application, and cartilage, and muscular dystrophy and aging. Those projects are not in clinic yet, but the goal here is to move this, and when it moves to clinic, then we bring this here, and we're starting to do the science back in Houston on other projects. So really, this is a pipeline that we're thinking that we're going to push forward. So again, you can be sitting in the room, when I left Pittsburgh, people were telling us, we learned a lot, we did a lot, but it's amazing that, although if you have done a lot of research, we still have a lot of problems out there. I mean, if you have a cartilage injuries, I'm a runner, and I wanted to run 20 miles. Story that just happened this week. And I started to have pain in my knee, and Rob Laprade, take a look at my knee and did an MRI, and I have chondral lesion. I have 2 chondral lesions, in my knee. So he said to me, Johnny, maybe you should quit running for a while, because you're going to need a problem. You're going to have a problem. You're going to need a knee replacement and that type of thing. So again, it's amazing that if you have a cartilage damage, nobody can do anything for you, really. I mean, they can try to do something, but now the stem cell therapies and everything. But why I'm telling you this is because we have a lot of things we don't know. And I think with this institute, having clinicians working with scientists together, maybe we're going to be able to try to bridge this gap here. Because for me, when you have, an articular cartilage injuries and you are 45, 50, you're in bad shape, because if you need a joint and those joints last 10 to 12 years, then you're going to need a revision at 60, 65, and that's not something you want to do. So this is why, we want to develop approach to improve tissue repair. So here I'm going to give you a couple of projects that I think it's exciting, and I hope I'm going to make you, excited about. So here is really, what we have been working on for the last 20 years. We found a population of cells from your muscle, and we found that those cells are stem cells, because they can become every single cell type in your body, basically. You have to push them, and those cells can become, a blood cell, they can become a muscle cell, they can become a chondrocyte. Not only if you stimulate them in vitro, but if you put them in an animal model, they can repair those tissues as well. But they can also become, hepatocyte, urinary bladder cells. This is why we have these clinical trials for stress urinary incontinence. But, they can also become nerve cells, neurons, and glial cells. And now we're using this to repair, nerve injuries. So here is really, the summary of what we're doing in the lab. So the idea behind this, we take a muscle biopsy from you, we isolated your own muscle cells, and now we can use them to repair your bone, your heart, your nerve. And again, the good thing about this is not because the stem cells are the best in the world. The good thing about this is because those stem cells are from you, and we inject them into you. So this is why, this is, because we don't have any immune response, and that's very important, because if you think about embryonic stem cells, people talk about it, but embryonic stem cells will never be from you, obviously. They are come from, an embryos. So therefore, one of the main problems with embryonic stem cells is rejection. So this thing here, it's really, a good application because you cannot bypass, the immune response in a way. So we're using this to repair skeletal muscle and nerve after injuries, either in sport or military injuries. We're using this to repair bone and articular tissues, like I told you, cartilage, meniscus, and ligament, to repair the heart. And the thing that I know you're going to be excited about is we're trying to delay aging with those stem cells. And I'm going to try to show you a couple of examples here. But like I told you, we already enter the clinical arena, for the stress urinary incontinence. I told you we have over, 400 now is 500 patients that has been injected, and we're in phase 3 clinical trials, and this thing is going very well. And more recently, like I told you, we use the same approach now, but now we inject the cells into the heart after a myocardial infarction. And the goal there is to improve cardiac repair after the injuries. There we have only 10 to 12 patients because we want to finish this phase 3. When I say we, it's not really me. It's the company that I founded probably 10 or 12 years ago called Cook Myocyte, and they licensed this technology from the University of Pittsburgh. And now they basically recruit all my graduate students. They have over 100 person working for them now. And again, that's very exciting because they are really pushing these technologies, and that's going very well. So one thing that I got excited about is I wanted to ask, where those stem cells come from. And a lot of people may say, why do you want to know that? Because I was telling, I was saying, talk about adipose-derived stem cells, and I was asking them where the cells come from. And the person was telling me, well, what's the point? Because I know if I take 5 grams of fat, I get enough stem cells to repair that bone. But I'm going to show you where the stem cells come from. It's very important. So here we found that the stem cells from muscle come from the blood vessels. So you can see blood vessels here, and what you see in red here are those pericyte, perivascular cells. And we found that those pericyte and endothelial cells are at the source of muscle-derived stem cells. And we even found that the pericyte is at the source of a lot of stem cells, not only muscle, but bone marrow and fat. Actually, we believe that all the adult-derived stem cells that people have been talking about are from the blood vessels. And it makes sense because the only tissues in your body, one of the few tissues in your body that doesn't have any blood vessels is cartilage. You have very few stem cells in cartilage, and when you have a damage in your cartilage, it's never going to heal unless you do something, like you try to stimulate. So the bottom line is it makes sense that stem cells come from blood vessels, and maybe all the adult stem cells come from blood vessels. But what we said after that? We said, well, if that's true, then if we increase the number of blood vessels, we should be able to improve tissue repair. And how can you increase the number of blood vessels? It became clear to me that exercise is a very good way to increase the number of blood vessels, because when you exercise, you increase angiogenesis, therefore you create blood vessels, and therefore, maybe you have a better tissue repair because, exercise and neuromuscular electrical stimulation. So this is what we did. We said, maybe that's why we feel so good after training, because everybody's thinking, well, when you go and run, you feel great, and you have this burst of endorphin, and that's it, right? You feel great. But they have something more biologic behind this. So in order to prove this, then we put mice on treadmill. And those mice, again, mice in Houston, mice in Vail, mice in Pittsburgh, they are very lazy. They don't do anything. If you put food in their cage, they eat, they drink, and they sleep. That's what they do. So what we do is we put them on treadmill. And as you can see, on those treadmill, they have no choice. Because when they back up, they have to come back, because here's a rotor, and they don't have any space. So what we did is we put mice on treadmill, and we asked the question, if we train them, and we compare this to those mice that are sleeping in their couch, and we ask the question, are they going to have more blood vessels? Are they going to have more stem cells? And are going to heal better after injuries? And this is what we found. We found that the stem cells come from the blood vessels and endothelial cells and pericyte. And when you do exercise, you increase angiogenesis, you have more stem cells, and you heal better. And this is clearly, we have published paper that we put mice on treadmill, and the repair process is significantly better. The same thing with neuromuscular electrical stimulation, which is a rehab technology that a lot of people use, but they don't really know how it works. So I just would like to say that this thing is very interesting because for us, it really showed that exercise is very important for you. But the amazing thing, it fits so well with the mission of the Steadman Clinic, keeping people active. This is what you do here. Everybody around here, what they do is they run, they bike, they ski, they do everything, but they are very active. So I really believe that this is very important. So the bottom line here, what we're thinking is when you exercise, you increase the number of blood vessels, and therefore you increase the number of stem cells. And therefore, if you have more stem cells, then you have more growth factor that those stem cells are going to release. And you not only, you heal better, but you age better and healthier. And again, recently they have papers that have been shown that exercise can delay aging. When you exercise, you're going to have problem with your hip, knee, and ankle and everything. But we have a lot of orthopedic surgeons that can take care of that. But but the people who exercise look in general younger than the people that do not exercise. And here, look at the papers, not from us. Moderate and intense active lifestyle attenuate delay the effect of aging. So this is published in 2016. This paper here, exercise induce change in capillary, like I told you already, in the cortex, in the brain. And that, delay the deleterious effect of brain aging, which is very important. The third paper here showed that mental and physical activity delay cognitive decline in older person with dementia. And finally, the bottom line, what I'm trying to tell you here, exercise is very good for you. And if this is something that I want you to that you bring home with you tonight is this. And we know very little about this. But I just would like to say something also that, the study that I showed you that we put mice on treadmill, okay, we increase the number of blood vessels. I was in Notre Dame, last year, and they did the same thing. They put mice on treadmill, and the other mice, they were not on treadmill. But instead of injuring them to see if they heal faster, they inject cancer cells that will kill pretty much everything alive. And all the mice that were not running, they all die, which is expected. But over 50% of the mice that were training, they survived that tumor, which is pretty amazing, and nobody understands why. So this is why, the NIH now is putting a lot of emphasis on exercise and how that, affect, your blood vessels and stem cells and so forth. So now, I have to talk about stem cells and aging because it's amazing because to call our stem cells, it took us 10 years with the FDA to convince them that we had really stem cells. But you can go at Macy's or, at Nordstrom and you can buy a stem cell therapy cream out there. But, folks, this thing doesn't work, and you know that probably, right? It works probably between your ear, but it doesn't work in reality. And sometimes they put this and they said, hey, the wrinkles are gone. But 2 minutes after, the wrinkles are back. So the bottom line here, but the point that I'm trying to point out here is really that they have a huge market, stem cells and aging. And the goal is not to make you younger. The goal is to make you age better. So this is what we wanted to do. We wanted to see whether, and again, I'm trying to picture here, what's happened when we get old. When you get old, when people tell you that we're getting better, that, in terms of stem cell, this is not how it works. So when you're young, so in here, I put stem cells with this little diagram here and growth factor with those little things here, okay? Growth factors are the thing that the stem cells will release. So when you're young, you have a lot of stem cells, and they have a lot of, goodies that I call, a lot of growth factor that's going to rejuvenate. This is why when you injure your muscle, you heal so quick because you have a lot of stem cells. But when we get old, then we have less stem cells, and of course, they have less goodies, so they release less growth factor. So that's really what this is proven. And again, we published probably 10, 20 papers on this, but people have shown this many times over and over. But what we're trying to do is we're not trying to take this guy here and make him younger. We're trying to stop this or delay this. That's this depletion of stem cells. So in order to do this, then we had to use an animal model. And you probably have seen, those patients, they are Progeria. So those patients, are maybe 15 years of age and they look like 85. They have wrinkles, they have osteoporosis, they have neurodegeneration. This is an horrible disease. So it turns out that at the University of Pittsburgh, a collaboration of ours, Laura Nidenhofer, she basically knocked out the genes that it's a DNA repair endonuclease, okay? So what that do basically, you're sitting in a room right now, you eat a sandwich, you probably have stem cells dividing in your blood right now. And if the stem cells, when the stem cells divide, they make 2 cells, 4 cells, 8 cells, 16, then you have DNA damage. And those enzymes here, what they do, they repair the DNA damage. And if you don't have them, then the cells accumulate DNA damage and the cell's gonna die. And this is clearly what's happening in those patients. They don't have this endonuclease, they don't repair their DNA, therefore when their cells divide, they die, and that's the problem. So we create these mice here, it's a full knockout mice, they don't have this endonuclease, and sure enough, these mice, live 21 days, and the normal mice live 2 years. So those mice, they go rapidly through the aging, they have all sorts of problems, sarcopenia, osteoporosis, renal and liver dysfunction, loss of vision and hearing. Those mice age in 21 days, basically. So we wanted to prove, we said, if we take the stem cell from those guys here, and we compare this with those guys, maybe the stem cell will be different. And sure enough, they were. So here you can see that the stem cell from a normal mice, you have a lot. What you see, those circles here are stem cells. You have a lot of stem cells, and they are very active. Here they make myotubes or immature muscle fibers. They differentiate into the myogenic lineage. The Progeria stem cells, you have less stem cells. They don't differentiate it very well, and they don't proliferate. So the bottom line, after we published this paper, we said, well, in this Progeria mice, we have fewer, and we have dysfunctional stem cells. And I call them tired stem cells, because those stem cells, you have very few of them, and they don't do anything. They don't proliferate. They don't differentiate. So after this is what, I think another part, of the talk that I really want you to remember. So here what we did, we took those mice. I told you they die at 21 days of age, okay? And I told you that their stem cells are depleted. So what we did, we took those mice at 17 days of age and we inject 500,000 of a young stem cell from a young mice. We inject this into their belly cavities and we ask the question, can they live longer than 21 days? That was really the goal here. And this is what we observed, The mice, that are injected with, not with the young stem cell, they injected with the saline solution, they die within 20 and 21 days. But the mice, injected with those young stem cells, some of them live for up to 70 days. I have mice that live for up to 100 days. So we almost quadruple the lifespan of the animals. And that was not the most exciting thing because we want to increase lifetime. I think that's very important. But we want to increase health span because we want you to age longer, but healthier as well. Because what's the point to be at 100-year-old? You don't see, you don't hear, you don't walk. So this is very important, the health span. Look at those mice, 21 days untreated. Look at this mice, 45 days after transplantation of young stem cell. Not only they live longer, but they look better. And when I saw this result, in the lab, I didn't believe the result. That was too beautiful to be true. So I went to the animal facility and I talked to the people. I said, I want all the people that take care of those mice here. And I told them, I said, do you know that mixing those mice can be very, problematic for me because, and they told me, they said, we didn't mix the mice. I said, this cannot be a Progeria mice because, 45 days post-transplantation. And when we genotype them, we look at their genes, they were indeed deficient in the endonuclease. So they were really stem cells, injected mice. They were Progeria, and now they live longer. So what we can say here, the Progeria mice injected with young stem cells live longer and look better. And how that works, so I think this is really, we got funded by the NIH, to do 5 years of research to try to understand just that here. So one thing I want to say is I told you stem cells come from blood vessels, right? So when we look at the muscle of those mice, those Progeria mice, that die within 21 days, what you see in green is muscle fibers. What you see in red is blood vessels. You can see significantly less blood vessels in the Progeria mice. That was probably the reason why they age very fast because the stem cells get depleted, the number of blood vessels goes down. But the most amazing thing, when we inject stem cells into their belly cavities, we increase the number of blood vessels in their muscle, And we also increase the number of blood vessels in their brain because the mice, the Progeria mice has less blood vessels in their brain. But when you inject young stem cells, you increase the number of blood vessels in their brain, and the stem cell doesn't go in their brain. So that means they release something that, travel through the bloodstream and have an influence in the brain. So the stem cell rescue mechanism is still unknown, but rely on the secretion of growth factor that promote angiogenesis. More angiogenesis, more stem cells. So again, what that means for all of us here. So the way that I see the future of stem cell therapy is really the following. At birth, umbilical cord, any tissue that you can harvest stem cells should be isolated, bank right there. This is the best gift you can give to that newborn. When I see people buying teddy bear and flowers and outfit and everything, I said, maybe the best way is to get all this money and pay $3,000 and get their stem cell bank, because it's the best gift you can give to that kid. 20, 30 years later, then maybe they can use those cells to repair their knee, their hip, but also when they are just about to go and buy the cream for aging, then maybe they can use their stem cells. So here is really, so what we want to do, at birth, we harvest the stem cell from those newborn babies, we grow them, we make millions of them, we freeze them down, and after this, when FDA has approved this technology, we're approved for bladder and cardiac repair, but let's say FDA now approved this to delay aging down the road. Then we can harvest the stem cells, put this in a syringe, and try to delay the aging process. And again, here you can see the difference with Arnold, when he was younger and when he's older, so it's pretty clear. So the goal here is to really try to delay this aging process. And right now, I just would like to say that the same approach can be used for those soldiers, all the soldiers being deployed to Afghanistan and Iraq. So now they have a push from the Department of Defense to have all their stem cells banked. In case something happened, then you don't have to reinvent the wheels. I'm also involved with the NASA. The NASA is very important, is very interested, to team up with us so we can harvest stem cells from those astronauts before they go to the moon. Because when they go out there, they face a lot of radiation. When they come back, those astronauts, they have all sorts of problems. So maybe we can reinfuse their own stem cells. So this is really what we're doing right now. We are in the process of establishing a stem cell bank. We're going to start this in Denver, because they have a Gates Center over in Denver, but down the road, that's going to become, a pretty big, deal. So we're going to need, expansion. But the idea will be to isolate the stem cells in a younger age. And we can do this for us too, because, I just would like to say that, of course, a newborn would be the perfect thing, but for us, it's a little bit too late. So we're a little bit older. But the bottom line, we're all 5, 10, 20 years younger today than 5, 10, 20 years from now. So maybe, we can harvest our stem cells, and if we put this in liquid nitrogen, we stop their aging right there, and in 20 years down the road, maybe we can use them. So again, how we're going to use this. So here is really, me thinking about it. So when you have a kidney disease, what you do is, you go to VVMC or whatever, so they take their blood, they connect you to a machine called dialysis. They take your blood, they remove the waste from your blood, and they put the blood back. This is how it works, right? So we would like to do the same thing, but now instead of removing the bad stuff from your blood, we're going to put the goodies back in your blood, the goodies from your young stem cell that we had isolated probably 10, 20 years ago. And again, at the latest, if that doesn't work, at least that has a scientific basis behind it. And I think this thing will be better than the cream whatsoever. So I think, this thing is a better way to go. And again, remember that we are 5, 10 years younger today than 5, 10 years from now. So this is really, something that we're trying to push. Now I want to talk about PRP. Because PRP right now is, you probably know, some people use PRP, some people doesn't. I was at the American Academy of Orthopaedic Surgery at one meeting, and they asked the people in the room, raise your hand, the people who believe in PRP. Half of the room probably raised their hand, the other half hates it. And that's really why it hates it, because we don't know how it works. So PRP, we take your blood, we spin it down, we take the platelet-rich fraction, and we inject this into your knee, into your hip. Actually, Peter Miller did this when I had my injuries. He said, do you want PRP? I said, yes, why not? Let's put PRP in, and I heal pretty fast, but I'm a hand of one. But I heal pretty good. So here is really, platelet-rich plasma, we come far because, in 2010, I was involved, with Mark Philippon here. We were involved by the IOC, the Olympic Committee, the International Olympic Committee, because they wanted to know, is PRP doping? Because if it is doping, we have a problem because we have no way to detect this. Because this is not like the steroid that we have a test for it. PRP can be, something is from you injected into you. But what we found is clearly, from this meeting, we said PRP is safe. But we don't have any way. We don't have any standard with PRP. Everybody uses it a different way. Everybody uses it, the way it prepares it. It's all different. And clearly, we need more basic science behind PRP. And I'm going to give you an example of what we're trying to do here and what we're trying to do at the Steadman Philippon Research Institute. So again, here this is PRP, okay? And again, you have a lot of factors within your PRP. Some of them are good, some of them are not so good. But some of them can promote cell proliferation, migration, recruit inflammatory cells, stem cells. That's perfect. That's really what you want. And this is why, a lot of people believe in PRP because they have all those growth factors in it. But it's like, it's a mixed bag because PRP contains a lot of stuff too, and those stuff are not so good. They can trigger inflammation, tissue damage, and matrix degradation. They are within PRP, and that's probably why the people doesn't believe in PRP is because of that. Because PRP is not always good. So us, we said, well, maybe, because a lot of people that work on PRP, they said, they were telling me, they said, to really understand how PRP works, you have to understand everything in PRP. And this is kind of stupid when you think about it. Because you have a lot of things in PRP today that we don't have a name for it. Because the protein is not discovered yet. We're going to discover that protein 10 years from now. So what we decided to do with our team, we said we may not need to know all what is within PRP, but we may need to know the bad guys. The one that you don't want there. And maybe we can neutralize the bad guys, the TGF-beta1 or the growth factor that will be detrimental to you. So this is what we tried to prove. So we said, well, PRP has a lot of things in it. So what we can do is, if you want to use PRP for cartilage, you don't want VEGF there or angiogenesis because you're going to destroy cartilage. If you want to use PRP for muscle, you don't want TGF-beta1 there because TGF-beta1 will trigger scar tissues and the muscle repair is not going to be good. And of course, if you want to use PRP for bone repair, you don't want noggin because noggin blocks bone repair because it blocks BMP. So we decided to do this, to prove this hypothesis here. So of course, to do this, we have to do experiments. So we took mice and we did an injuries. We did a contusion injuries. We injured our muscle like you get a blunt injuries, like happen in football all the time. And some of them, we gave them PRP. Some of them, we gave them nothing. Some of them, we gave them PRP. But some of them, we gave them losartan. Losartan block fibrosis, block TGF-beta1. And some of them, we give them PRP plus losartan. So the idea will be the PRP plus blocking TGF-beta1. And we ask the question, are they going to heal better, the one that we combine losartan with PRP? So as you can see, when you give PRP, here is fibrosis, by the way. When you give PRP, you can see that you increase fibrosis. Of course, because you have TGF-beta1 within PRP. But if you combine PRP with the blocker of TGF-beta1, you significantly reduce fibrosis and you increase muscle force. Showing clearly that if you want to use PRP for muscle, you better take out TGF-beta1 from it. So, and that really was published, in GBGS, where, a good friend of mine, Chris Evans, said, platelet-rich plasma à la carte mean, you can tailor-made the PRP for that particular use. And again, looking in the area of personalized medicine, there is a potential to customize PRP for individual need. So if someone tells you PRP is good for muscle, bone, cartilage, ligament, and meniscus, and spine, then you may say, well, it's maybe too beautiful to be true. So clearly, if you want to use PRP for muscle, then you want to take out the TGF-beta1. And what we may want to do down the road is maybe we can design a syringe. That in that syringe, we will have antibodies that will take out TGF-beta1. When you push in it, all the TGF-beta1 will remain in that syringe. So therefore, you're going to make sure that, you don't produce, fibrosis. Personalized medicine, one product, each tissue, muscle healing, blocking TGF-beta1, and promoting angiogenesis is all the best way to improve muscle repair. So clearly, this is one application. We did the same study. I'm not going to go in details here. Same study for cartilage, where we found that if you block VEGF, you will improve the beneficial effect of PRP for articular cartilage. And here, if you want to use PRP for cartilage, maybe you can have the same syringe, but instead of having antibodies against TGF-beta1 now, you're going to have antibodies against VEGF to remove VEGF from the PRP. So like this, you make sure that you optimize PRP for cartilage repair. Where are we today? So I think this is what we're trying to build here. This is not easy, and I want to thank the people in my lab, because we're working very hard, because we want to optimize PRP. Of course, we want to remove and neutralize the deleterious factors within PRP, but that may take years to do this. But what can we do now? So what we want to do now is really every time that someone's going to inject PRP or BMAC here at the Steadman Clinic, we're going to take a fraction of it. We're going to try to preserve it. Okay, so they inject 10 mil. We're going to take 1 mil out of it, or 0.5 mil out of it. We're going to bring this in the lab. We're going to freeze it down, and we're going to do proteomics and cell culture. We're going to do real-time result, and we're going to try to correlate this to the clinical scenario. So in other words, I'm going to bring PRP in the lab, and we're going to do a lot of analysis on this. And after this, I'm going to try to correlate this with the clinical scenario. I'm going to give you an example here. So here, PRP and BMAC that the surgeon inject to the patient. So we're going to get a fraction. We're going to go in the lab, try to understand what is within PRP, and the goal is to optimize this application. How are we going to do this? Here you have a machine that we're about to buy. That's going to be, I've been told that we're going to buy this machine within the next few weeks, which I think will be great, okay? This machine here, you put the PRP in this, and they can tell you 25 different growth factors within PRP. We can custom made. I can make an educated guess. I can probably tell TGF-beta1, VEGF, interleukin, and I can make my wish list of growth factor. And I'm going to get, this graph for every PRP that you inject. And look at the growth factor we can look at. And I'm going to try to correlate this to the clinical scenario. So in other words, when someone injects PRP to a patient, then 2-3 weeks later, we're going to have the patient, are you feeling better? Yes, my God, I'm feeling great. Then we're going to say plus, beneficial effect of PRP. And we're going to try to correlate this with what all the beneficial effect of PRP, what they have in common. Is that one growth factor is always high or always low? And after this, the goal here will be to be able to tell the patient, down the road, and maybe if we know this, then we're going to optimize PRP. And who knows, maybe down the road, if we found that this protein here, TGF-beta1, is always high when the PRP is always good, okay? Then maybe you can take a blood sample before you do PRP to this patient, and if we can check in the blood, if TGF-beta1 is high, then you can tell, well, I think PRP may work for you. That would be great, because now when we inject PRP, we don't know, sometimes it works, sometimes it doesn't. So that will be the science behind it. The same thing when we inject BMAC. When we inject BMAC here, BMAC is bone marrow aspirate. They have a lot of cells there. They have, probably, bone marrow stromal cells. You have probably blood cells. You have probably perivascular cells, endothelial cells. So what we're going to do, every time that they're going to inject a BMAC, we're going to bring this in the lab and look at the cells that we have in that BMAC. And when we're going to try to correlate that, and when the BMAC work in those patients, we're going to try to correlate which cell fraction is higher. And maybe down the road, we can optimize the BMAC that way. So I think that's really something we're trying to do today. But, of course, down the road, we want to make PRP better. We want to make those syringes where we're going to pull out the bad stuff within PRP. I know I was asked to talk about spine, and I said, I don't have a lot of things. I don't do a lot of things on spine, but I wanted to share something with you because I know in spine what you do is spine fusion. You do this all the time. And you use BMP for this. And BMP, as you know, is very expensive. So can we get something, less expensive for you? So I just would like to say that stem cells is very good to make, bone repair. And here, it's an example. So we took, muscle-derived stem cells here, and we basically engineered them to secrete BMP2 or BMP4. We put a virus inside of this. Of course, we cannot do this in patients, but those cells now secrete a lot of BMP2 or BMP4. And what we did, we tried to heal a skull defect. So we make a skull defect in those mice, and we ask the question, can those stem cells heal the skull defect? As you can see here, the mice that were not treated, you can see the skull defect here. The brown is bone, no bone in the defect. But the one that was treated with stem cells, we make a large amount of bone, and you can see that those cells become osteoblasts. So they can really, improve bone repair. So when we did that study, people said, well, that's nice, good bone, but is the bone biomechanically good? So in other words, can this bone sustain load? So we move, to a long bone here, the same thing. So we create a critical size defect, and now we use stem cells with BMP4 here and into a gel foam, which is a scaffold. And we ask the question, can we heal the bone? And here is really what you can see. The control group here, you can see no bone forming in the defect. But the defect treated with BMP4 expressing cells at 6 weeks, you start to see a very nice bridging of the defect. By 12 weeks, you have a full bridging of the defect. And of course, we wanted to look at bone mineral densities. And as you can see, the one treated with those stem cells expressing BMP4, you have bone mineral density that is increased compared to the other group. And when you look at biomechanical, testing, torque failure, torsional stiffness, you can see that the MDSC's BMP4 is almost similar to the intact femur that has never been injured, showing that we can make bone, and the bone seems to be pretty good. And maybe this technology can be used on the road for spine fusion. And again, this is, this is an area that I know in spinal injuries is very important. Here is really, the thing that I really like, bioprinting. I don't know if you know anything about bioprinting, but this is amazing. You have a group of very, very talented scientists from MIT, Carnegie Mellon University. What they decide to do is they decide to take an inkjet printer. And when you have an inkjet printer, what you do, you write on your computer, okay, so we have a great speaker tonight, okay? And after this, you send this to your printer, and it prints, letters that make words and words that make sentence, right? So what they decide to do, they decide to use the same system, but instead of printing ink, they print BMP, or they print VGF, bioactive molecules. And now, they can really do this and make tissues, 3D tissues, and a lot of people really believe that this technology down the road, we're going to be able to print maybe, an implant that can be used, for, joint arthroplasty or, and so forth. So we decided to do this in Pittsburgh, and we collaborate with Carnegie Mellon University, and here what we did, very simple. We took this flask here, culture dishes, and we print in that little square here, BMP. And that little square, FGF. BMP promote osteogenesis, FGF do not. And after this, we put the cells on it, and it turns out that where we print BMP, then all the cells there turn into osteogenic cells. They express alkaline phosphatase, and they express all the markers of osteogenesis. In that little square, we make bone. In that little square, we don't. That's important because if you want to develop an implant down the road that can do cartilage and bone, then you have to have a layer of cartilage on the top and a layer of the bone in the bottom. That's really the idea behind this. So we went a step further with this. And we said, okay, so now we're going to use a scaffold. Here we use a scaffold where we print half of the scaffold here with BMP. And after this, we see the cells on it, and the cells on the BMP side, they turn osteogenic, right? And after this, we use the scaffold, and we repair the skull defect in those mice. And where we print the BMP, the bone forms. When we don't print the BMP, the bone doesn't form. So we can control the amount of bone that we can design. So the bottom line, down the road, we really believe that we can. This is not ready for prime time, but this is just to give you an example. Okay, we're looking in 10 years in the future here. So you see a patient coming here, is going to an MRI, and now your knee, my knee, his knee, her knee, it's all different. We all have a very unique knee. So we can basically scan this, and after this we do a stem cell harvest from the bone marrow, from fat maybe, because everybody wants to give their fat away, so maybe fat will work. And after this, you put the cells in cultures, and of course, you basically stimulate them with growth factors and so forth. And after this, when the cells are being multiplied and everything, then after this, you can start to do your bioprinting, okay? So now you're printing, let's say you're printing a knee, okay, an artificial, knee here, or a knee implant. So you print your knee with the material that they're using right now. This is all foreign materials. But at the end, when you finish to print, what you can do is you can do an additional step, because remember, we have frozen your stem cells down the road. So I think your stem cells are there. We can put your stem cells on it. We can put the growth factors in it. And this hybrid will become like an hybrid knee. So the idea behind this is, you know that an artificial knee is 100 foreign, has nothing from you in it, and they last 10 to 12 years. So the bottom line here, can we make a knee that's going to be half you, half foreign, because we can put your stem cells in it. And the goal here will be to have, this knee last longer than 12 years. And I think we can do this. We're not ready for that, but that's really what we're trying to do. So here is really to finish by saying, you know what? You may think tonight that I'm talking about something that this is probably never going to happen. But look at the cell phone, or if you can call this a cell phone, and look what we have today. And again, today the iPhone 6, the iPhone 5, is foreign. We all have an iPhone 6, and maybe in a few months from now, we're going to have the iPhone 7. So this technology is changing. They make it smaller, they make it smarter, they make it to do a lot of different things. And I really believe that regenerative medicine is not going to change the way you do surgery. It's just going to give you maybe a hedge to repair this a little bit better. And again, what I'm really excited about is if we can harvest the stem cells early on in life, then we can use them. We don't have to harvest them. So that's really what I was trying to show you tonight. And again, here I just would like to thank the people that we have in Houston. And again, here we have a group of people in Houston, and we have surgeons working with us and postdoc and supporting staff, which I think is very important. And we have also our group in Vail. And again, here we have the group that we have built. I'm very happy, very supportive, surgeon that's going to work with us and staff. And again, I just would like to say that some people ask me, why Houston and Vail? Because this is clearly the opposite. Houston is huge, Vail is small. Houston is so warm during the summer. This is why I'm here, by the way. Vail is so cool, it's so great. So the bottom line, between the two, I cannot have a better scenario, because when it's very cold here, I can go in Houston. But when it's very warm out there, I can come in Vail. So I would like to thank you. And again, my goal tonight was to give you an overview of what we're doing. I didn't go in science, but if you're interested, our lab is just next door, and you can email me, or I can go in detail with you on some project that we're doing. So thank you. Yes?
Are fat cells pluripotent the same way that muscle stem cells are?
I think fat cells, are as good as muscle cells or as good as bone marrow, because fat has blood vessels in it. But for some reason, if you take a stem cell from fat, what they do very well is fat. If you take a stem cell from muscle, what they do very well is muscle. If you take a stem cell from bone marrow, what they do very well is bone. You can push them, though. You can take a fat cells and make bone out of it. You can take fat cells, make muscle. But I always say that if you want to repair muscle, what I talked tonight about is the best cells to use muscle, for muscle. If you want to use bone, then maybe the bone marrow will be better. I'm losing my voice. So again, I think that's really what's happening here. So they have different source of stem cells, but sometimes where you get them from a tissue, they are better to repair that tissue. Well, my God, my voice is going.
So how about potential risks? I'm thinking back to the study where you're injecting the mice with stem cells and promoting angiogenesis. What about a patient who might have undiagnosed cancer or something like that? Might that kind of speed that along?
That's a very good question. And actually, I didn't talk about this, but you may think that very scary. But if you take stem cells and the cancer cells, they are very similar. So strikingly, stem cells can divide and make a lot of stem cells. Cancer cells can do the same thing. Stem cells, can make a lot of different tissues. Cancer cells can do as well. Stem cells, are very resistant to stress. Cancer cells, you cannot kill them with anything, right? Radiation and chemotherapy. Stem cells come from blood vessels. If you want to kill cancer, if you can block angiogenesis, you're going to kill that cancer. So I think they have a lot of things in parallel. And I think what you raised is a very good point. So if you have someone who has a predisposition for cancer and you inject stem cells, maybe those stem cells will become cancer. But I used to say, and people tell me, you have injected 400 patients with those. And if those cells can become cancer, are you afraid that they develop a tumor or something? And I tell those people, We have a lot of people in the room here that never have any stem cells, and some of us are going to have cancer. So I'm saying that cancer, I believe that stem cells can become bone, they can become cartilage, they can become cardiac cells, they can become bone cells, they can become cancer cells too. And what we're doing at MD Anderson, we take a stem cells and we push them toward cancer cells. And we're trying to develop drug to block this process to occur. And if we find this, then we may have found something to really block cancer. So don't be surprised that down the road we're talking about regenerative medicine to repair bone, cartilage, ligament. But maybe those stem cells, after all, is going to give us cues to try to block cancer. But your point is there. The point is very well taken. And again, this is why I'm saying that when you repair a tissue, then it's very important the local milieu where you inject the stem cells in it. Because if you have a bone fracture there and you have a non-union, you have no blood vessels, even if you inject 20 million cells, you're not going to do anything there because they're all going to die. So I think where you inject the stem cells into, you have to make sure that that milieu is conducive for stem cell repair. And that goes the same way for cancer. Cancer is always a very good question, and I think that, I can say that we have over 500 patients injected. None of them has developed any cancer. This is where in phase 3, and now we're moving to past phase 3. That's going to be the healthcare approved at one point. But I cannot tell you that tomorrow is not going to have one. But I think it's really, we're really on the boundaries, and people say, are you afraid stem cells are so similar to cancer cells? And I'm saying, you know what? Maybe we can learn from it. And down the road, I'm even thinking, okay, down the road, what we do with a tumor. When someone has a big tumor, the first thing that we do, we take this and yuck and put this in the garbage can, right? You probably have the best stem cells in that tumor. You have a lot of cancer cells there, but you have a lot of good stem cells there too. So maybe down the road, we can use that tumor to bank your stem cells. But this is 10 years down the road. Did I scare you now? No more question? On aging, nothing? Yes?
With those Progeria mice, did you ever do a follow-up study to see if injecting additional stem cells, 20 days out more, and then maybe doing it every 20 days to increase all the mice life beyond 100 days?
Yeah, well, that's a very good question. We published this paper in Nature, and it took us 5 years to publish that paper because Natures are very tough, okay? They asked us to repeat the injection. So those mice, we inject them. They live for 75 days, but they're picking down, right? What we did is we inject stem cells back. So they went a little bit further. We have mice that go over, 120 days, but they are still dying. So that means it's not a cure. It's a way to improve the lifespan, but still, and those mice doesn't have any endonuclease. So that means the cells are secreting something that rejuvenate those mice. So what the NIH, wants us to do is to find, what is that thing that they release the young stem cells. So we're doing a lot of proteomics. We're looking over all those proteins that are secreted by young stem cells to see what they can do. But you're right. I mean, if you re-inject them, you give them another burst. If you keep doing this, but they're still going to die from liver failure. Those mice die from liver failure, and that's because of the endonuclease. The liver is more affected.
What about the study that you're doing here with the PRP and the patients here? Given that patients can be so variable in their presentation, what outcome measures are you going to be tracking, and which ones do you think are going to be most relevant to your study?
Well, that's really, I think we can do pretty much everything. I think I can probably characterize 25 growth factors. I can probably tell you, which growth factor play a role. My problem is going to be what clinical factors that I use to say that PRP is beneficial. Because for me, listen, Peter Millett, is he here? He is a great surgeon. He repaired my tendon, and the day after, I didn't have any sling, but he injected PRP. So I'm giving talk, and I said, I got PRP too. But can I say that the PRP is the reason why I recover so quickly? Because I'm very active, I run, I do a lot of things. That's really the problem. The problem is this is very subjective to the opinion of the patient. Sometimes they have a good day, and they say, oh yeah, PRP is great, and maybe, so I think we're going to have to develop criteria for bone repair, for cartilage repair, to really look at the healing process as well. because not only how the patient feel, but also, if the bone heal faster, is the cartilage heal faster, and therefore that's going to be really our criteria. But we're going to develop this with the patient here, and the goal for me is to try to find, because we know nothing now. I told my team the other day, I said, we cannot fail in this project because we know nothing now. I mean, anything we can find is going to be good, right? So, but the bottom line, I think to know what you inject to the patient is going to be important. Because let me tell you something, PRP, we found that PRP has no problem if you use this in sports medicine, muscle, tendon, ligament, meniscus, whatever. They have people who inject PRP in the heart in cardiovascular now. They have people who want to inject PRP in the brain for neurodegeneration. And there is really the problem. Because there, if you kill a patient, then you're going to kill the entire field for 20, 30 years. So that's really we were working on gene therapy. We were delivering gene with a virus back in the day. When I started my graduate studies in mid-90s, and I thought that gene therapy is going to cure all disease on earth, because gene therapy can basically deliver genes and everything, right? Until someone in Philadelphia, in UPenn, inject a virus to a patient, and he make a huge immune response, and he die from it. After that, don't even talk about gene therapy for the next 20 years. Now people are starting to talk about it. So I'm afraid that by injecting PRP to patients that you don't know what you're injecting, maybe I hope that we're not going to have, a major problem that someone, not in orthopedics and sports medicine, but in cardiac and neurodegeneration. And after this, you cannot talk about PRP. Everything is banned. Boom. So that's the FDA will block this like this. So I think even if we cannot correlate this with a good outcome, I think knowing a little bit more what we inject will be great, and maybe blocking the stuff that we don't want there. And that's going to be a learning thing. And this thing we can do it here, because they inject PRP all the time, so we can just, bank it and, try to correlate this with the... And one thing I want to say, I didn't say that here. People are using young PRP now from a young mice to rejuvenate a whole mice. So PRP, we talk about stem cells, right? But PRP has a lot of things in it. And I think now people are using PRP to rejuvenate whole mice. So maybe down the road, we're not going to bank only stem cells, we're going to bank PRP as well at birth. And that will be something. So PRP can be good. So you're all tired. The stem cell cannot help that. So thank you so much, Jen. Thank you.